Thank you. It's both a pleasure and an honor to be here. I can tell you I think Toronto is one of the coolest cities I've ever been in, and it's a true honor to be here. I came into this sort of by a circuitous route. I started out life as a surgeon. I then went to medicine, then went to cardiology, then went to electrophysiology, and then sort of started to fell by accident into doing autonomic research, and then from that into this. So I'm going to try to summarize 30 years worth of research in a very short period of time. So when normal people stand, to give you an idea of what the autonomic system does, there's two parts of the nervous system, somatic and autonomic. The somatic is the part you're used to thinking about. The autonomic is the part that controls things you don't normally control or think about, such as temperature, blood pressure, body temperature, bowel motility, skin turgor, sweating. All of that occurs automatically. All of it is interlinked. All of it functions as a single organ unit. So to give you an example, and again, just for the sake of time, when you stand, gravity will immediately displace 1/3 of your body's volume downward. That's anywhere between 500 and 700 cc's. The displacement is immediate. You must make immediate compensations or everyone would pass out. Most of us do not, because when that occurs, there's a stretch of the vasculature from the center of gravity down. Their vasculature is lined with special cells called mechanoreceptors. They increase their electrical output. The brain sees an increase in electrical output from the lower half of the body compared to the upper. It then, to compensate for that, it increases heart rate, increases the force of myocardial contractility, and virtually triples the degree of vascular resistance. The vessels just go like that, and it pushes blood up towards the head. And that all occurs like that. So you can jump out of bed, jump out of a chair, do double backflips, and your pressure will stay perfectly the same. Once you're upright, you must maintain it. If you can't maintain it, gravity wins, you lose. And more of your blood volume will be displaced downward. The more that's in the lower half of you, the less can be in the upper half of you. So how you would feel would be dependent on the degree of displacement. Small amount, you'll just feel tired. More, you'll feel like you can't think, can't focus. More, you'll start to get lightheaded, dizzy. More, you'll see black spots, get tunnel vision, and more, you will pass out. I have had this done to me experimentally using lower body negative pressure, and it's a most unpleasant experience. One of the backup systems that we have as humans, that's uniquely human, by the way, is called the skeletal muscle pump. And what that refers to is contraction of the leg muscles, and to a lesser extent, the abdominal and arm muscles, compress the venous system and propel blood back to the heart. A healthy set of legs can raise your pressure over 10 points. Many people who have autonomic disorders, regardless of the etiology, unconsciously become dependent on their skeletal muscle pumps for day-to-day function. They use them all the time. For most of us, you don't need to do that. Think of the people who stand all day. Surgeons will stand 8 hours to do a case and be perfectly fine. So for most of us, there is a backup system. It's a complex feedback because there has to be sensory input into the brain, and especially in an area called the nucleus tractus solitarius. Then it has to be processed. Commands have to be sent out to make whatever changes are necessary, and there has to be a feedback loop to say, okay, you've done enough. It's just like the machines we build. If you break that chain at any point along the way, it won't work. And so there are multiple ways you could screw the system up. There's not just one. So in the mid-1980s, Dr. Richard Sutton and Dr. Rose Kenny at the Westminster Hospital in London hit upon the idea that you could provoke periods of decompensation in a controlled setting by inhibiting the skeletal muscle pump. And the way that was done is by putting people on a table with a footboard made for weight bearing, inclining them to only 60 degrees. That's it. You don't want them all the way upright because then they're putting tension on their legs. And the only stress upon you is gravity. That is it. Big deal. Normal people, I stood there in 1988 when I first started doing this research, and we were doing lots of normals for almost 3 hours and just got bored. However, if you are dependent on your skeletal muscle pump and you take it away, you will crash. And what that allowed then not only was a diagnostic modality, but for the first time we could observe in controlled settings what was happening. So we could measure blood pressure, we could measure blood levels for catecholamines, we could measure abdominal impedance, we can measure skin impedance, we can measure respiratory impedance, we could do echocardiograms, we could do electroencephalograms, we could do sympathetic nerve traffic recordings. We could do anything we wanted because we could induce it while we were watching. And what we found is most of what we thought we knew was wrong. This is one of the first patients we did back in 1988. This was a woman who was a nurse who worked at a local hospital, who was fired because she had recurrent episodes of syncope. She got the $1 billion workup circa 1988 and was told what we tell everybody when we don't know what's wrong with them: you must be crazy. So she was referred to us, and this was still a research test. And we tilted her, and about not very long into the test, I remember she suddenly said, "I don't feel well, I think I'm going to." And you can see from this chart that her heart rate and blood pressure go to 0. At that point, she began to have convulsive activity, she was incontinent, and my nurse and I stood there and went, "Wow, that's pretty cool." So at that point, we thought we better put her down, and we did, and you can see that her blood pressure rebounds, so that if you found her laying on the floor, she'd be hypertensive. It's almost like a Somogyi effect with blood sugar, that there's a rebound hypertensive effect. So again, if you found her laying there, you'd say, oh, her blood pressure's high. And this is what her heart rate did. Many of these people, if you keep them up, depends on the amount of time, they'll all do this if you keep them up long enough, not only will you see a decline in blood pressure, but also frequently in heart rate. And so these can go on for prolonged periods. Indeed, I recently had a child with a loop recorder I put in who had 59 seconds of asystole during most of his periods. So we learned also that not everybody would pass out. Many people would just get the other symptoms I mentioned to you. They would get lightheaded, dizzy, vertigo, etc. These could mimic convulsive activity. Indeed, there's been a large amount of research suggesting that up to 40% of people diagnosed with epilepsy do not have epilepsy. They have a cardiovascular cause of it. There's been a number of papers recently suggesting that. You may not know this, but people with a diagnosis of epilepsy have a 6-fold increase in sudden death rates. Now, part of that may be due to epilepsy, and part of it may be due to the fact they have the wrong diagnosis. So we began to look at the patterns we were inducing during tilt table testing and trying to compare them. We started to see different patterns emerge, and the patterns we realized corresponded with the clinical symptoms that people were giving us. So we realized we were not dealing with a single entity, but a heterogeneous group of different disorders. Now, we began to make an organizational system. All organizational systems, by their very nature, are arbitrary. I have now spent the last 5 years doing 3 different sets of international guidelines, and I can tell you it's as much politics as it is science, if not more. And this is a quote. I've also taken a great interest in quantum mechanics because I think that the way we think in medicine is outmoded. I think we're stuck in a 19th century way of thinking. Physics a long time ago realized that the act of observing something changes it. And so this is a quote I've always liked. Since the measuring device has been constructed by the observer, we have to remember that what we observe is not nature itself, but nature exposed to our method of questioning. So we began to organize these into different groups. I do not have time to go over all these in detail. I'll just mention some of them. This is neurocardiogenic syncope. These people have an autonomic hypersensitivity syndrome that oftentimes begins in childhood. In childhood, they're frequently called reflex anoxic seizures. If you're in Europe or in North America, you'll be said you have pallid or cyanotic breath-holding spells. These people, the system will just cut out suddenly. And it can be at any time, and it can just stop, and then you'll have no blood pressure, no heart rate, and you will fall like a tree. And if you don't kill yourself when you hit the ground, you'll be fine until your next episode. So it's kind of like epilepsy in that way. We also began to realize that there was a second pattern that we called dysautonomic, and these were oftentimes in older individuals and oftentimes associated with other neurodegenerative disorders such as Parkinson's disease, where 30 to 40% of patients will develop autonomic involvement. And when you stand them up, all the blood in their body just will drain to the bottom half of them, and they will make no compensation. Their heart rate will make no compensation because they are completely deinnervated. These people are sick all the time. The autonomic system is dying in these people, so they don't sweat. They have severe constipation. They can't empty their bladders. They get like a neurogenic bladder pattern. The whole system is failing. In the early 1990s, we became aware of this pattern. This was actually from a ward clerk at our institution who had been an athlete, ran in the Ironman triathlon in Hawaii, was very well until she got a bad viral infection, and then said, oh my God, I can't get out of bed. I feel like my heart's beating out of my chest. I can't function. I feel like I'm going to pass out every time I stand up. So when we tilted her, you can see that her heart rate goes from 70 to 160, sinus tachycardia, and her pressure drops a tad, not much. And she said, oh my God, this is the way I feel. This is horrible. This is exactly what I'm feeling. And we noted that her legs suddenly turned red and then kind of blue and then purple. And we said, damn, that's pretty cool. So we brought her back the next day and we gave her technetium, which binds to red cells, and we did what's called a blood pooling analysis. So when you bind this technetium to all the red cells in the body, you can see the blood and you can measure where it is. And so laying down, she had a normal distribution, but standing up, normally 15% of your blood volume is in your legs, and she had 35%. So what you were seeing was a failure of the peripheral vasovascular system to constrict, allowing for excessive pooling in the lower extremities of blood with a compensatory tachycardia, since in these people, the brain and the heart were still talking to each other. And so you get this excessive tachycardia. Indeed, it can become so excessive that it becomes part of the problem. What is this like? This is just like heart failure. What happens, remember I said you got three things keep you upright: contractility, rate, and vascular resistance. In heart failure, you lose contractility. So in the decompensated heart failure patient, you increase rate and vascular resistance. Here you've lost vascular resistance, you increase rate and contractility. And the way these people behave physiologically is very much like heart failure. So again, as I said, in this group of individuals with postural tachycardia syndrome, although there are different subtypes that I don't have time to go into, for the most part, something is interfering with the ability of the peripheral vasculature to maintain vasoconstriction in the presence of orthostatic stress. And you can watch it occur. You can watch this phenomenon that we call acrocyanosis. If it's real spidery and has splotches in the middle, we call it livedo reticularis. It's really the same phenomena. That little gizmo you see there is a string gauge plethysmograph, and it measures small changes in volume. So not only do you see the acrocyanosis, but actually there's an increase in diameter of the leg that's subtle. So we began actually to give credit where credit is due, or blame where credit is due. The term postural tachycardia syndrome was coined by Philip Lowe at the Mayo Clinic. There was a time we were trying to give validity to these kind of ideas, and so we realized we had to measure some kind of really hard data. Well, heart rate and blood pressure are pretty hard data, and we looked at different distribution curves to look at what a normal variance could be in heart rate, and we came up somewhat arbitrarily with this 30 beat per minute thing, which I think now has come back to haunt us. But anyway, that was how we defined it. Actually, the people at Vanderbilt hated that term and only recently have started using the term POTS and prefer the term orthostatic intolerance, which looks more at the symptom complex rather than a fixed number. This is not new. This is a painting from the 1600s by Van Steen, who was actually the teacher of Vermeer. And this was the Dutch realist movement in painting. They also painted a lot of sick people because in Calvinist theology at that time, it was thought that if you were sick, you were specially chosen by God to go through test here on earth to prove your merit for the next world or something like that. Anyway, so if you look at her, and these people did super accurate paintings. If you look at this lady, she looks awfully pale, doesn't look well, and in bad people, if you put their hands down, they'll turn blue too. Look carefully at her left hand. It is blue. It is cyanotic. Her right hand, which is being held up, is white because the blood's draining away. And what is the doctor doing? He's taking her pulse. The first study that all of us agree was describing POTS was in 1871. It was by decosta. He did extremely accurate measurements. You read this, it is a model of scientific inquiry. He did not have a way to measure blood pressure, but he looked at heart rate changes and all, and actually documented the acrocyanosis, documented the symptoms. You have no question in your mind when you read this, he was describing POTS then. In the blood pressure cuff as we know it was invented in 1914, and then so Sir Thomas Lewis, widely considered the father of modern cardiology, published this in 1919. He published an exact description of these people. I was astonished when I first read this. He did extremely good measurements. He even figured out what was wrong just by intuitively looking at people, something we don't do anymore. One of my colleagues who got fired recently said, if you have to touch the patient, you've ordered the wrong lab test. But again, it isn't that this just happened, and there are reports of this throughout the literature. We just didn't really realize it. The term POTS itself was first used by McLean in 1944 in an article in the Journal of the American Medical JAMA, the American Medical Association Journal. And again, he described these people perfectly, all the criteria, just nobody put it together. So these are the criteria we use. They have to usually, we said long-standing duration. I think we're seeing people earlier now. We made some changes in the cutoff points, but they're sort of the same. If you look at what symptoms people get, these are the percentage of people that complain of a certain symptom. And we also realized we were dealing not with a single disorder, but a heterogeneous group of different disorders that had similar clinical characteristics. So it was a syndrome. We did these studies with matched controls. so that we could tell what was going on. This is the girl whose leg was blue before, or red. And you can see that compared to a matched control, her blood pressure is lower and her heart rate is higher. But what happened is we started seeing people that looked an awful lot alike. We started to see a lot of pale, thin, blonde-haired, blue-eyed women, and while there are other people who have hypermobility syndrome, this was the initial group that brought us to their attention, and we realized we were missing something. We were all seeing these patients with increasing frequently, particularly young people, and we didn't know what we were missing, but we were missing something. To give credit where credit is due, Dr. Peter Rowe at the Johns Hopkins Hospital, who is trained as a geneticist as well, realized that all these people had hypermobility or EDS3 and published the first paper in 1999 linking the two disorders. I show this to people now, and nobody knows who Gumby is. And again, you people know this. This is just a slide I use for teaching the medical students, and perhaps. It's a heterogeneous disorder, and as I've done more and more work with this, I realize that it's a really large spectrum of different things, and I think the reason we haven't found a gene for it is because there's probably multiple different ones. One of the things that's interesting is these people, their blood pressure and heart rate things are just part of a much larger picture. Indeed, some of the worst problems we have are with nausea and bloating. We have a bunch of children that are severely affected who actually live off feeding tubes that they have to have put in, and a number of problems, but one of the GI ones are sometimes one of the bigger ones. They have a bunch of other issues, and again, the other people at the conference will go into those. Now, when we started doing this, we as a group decided to use a lot of the American College of Rheumatology criteria with their system because it seemed a little bit easier to use, and we all had to use the same scale. These are the Byton criteria. These are some of the kids in our clinic. Gives you an idea of all the neat tricks they can do. These are the criteria that we've used for the most part for our research previously. These were published in the Journal of the American College of Rheumatology in 2000. You have to have a series of two major, and you can read it. We use this as our guide, and again, we just chose this because it seemed easier for us to use, and we all had to be on the same system to do any kind of logical research. One of my older patients said that similar to what our previous speaker said, that when I was smaller, I could twist myself into a pretzel, and I said, do you happen to have a picture of that? And she said, yes, I do. And it's amazing how many of these people go into dance and all. Now, my late wife had hypermobility syndrome and was a professional dancer in New York City. And I learned from her that the professional life expectancy of dancers is about the same as pro football players. It's about 4 to 5 years. And the reason they can get into dance, I mean, who else can touch their knee to their nose, is because they have these traits, but it also makes their joints fragile and prone to injury. And I didn't know this, but there's actually a second and third string in costume sitting behind stage. They call them first and second understudies, waiting, because if anybody gets hurt, it's just like football. You yank them off and put the next one in. These are some other pictures from our clinic. These are some of the acrocyanosis people that we see. So in Peter's first study published in the Journal of Pediatrics, he looked at a group of individuals. These were some of the characteristics, and I think they've actually stayed about the same. One of the major ones is cognitive impairment that seems to be in a large group of people and one of the more troubling symptoms. He published a much larger paper several years later, again in the Journal of Pediatrics, which is the leading pediatric journal, and showed an even tighter association. This was a paper that was done out of Israel. This was done a collaborative Israeli-British study. They looked at 48 patients with hypermobility syndrome. These patients were all diagnosed by Dr. Rodney Graham, who is at the University of London, who is considered one of the world's leading authorities on hypermobility and EDS. So it wasn't regular people. It was he made all the diagnosis, and these were asymptomatic individuals. They compared them to 30 healthy control subjects and did a whole variety of autonomic tests on them, and 78% of the asymptomatic hypermobility people tested abnormal. So basically what they concluded is they are predisposed to these problems, or to use, I grew up on a farm and was a construction worker before I went to medical school. They ain't put together right. I mean, and they're kind of accidents waiting to happen. And we've seen this oftentimes where people who had previously been asymptomatic are exposed to some major stress, be it surgery, cancer, whatever, and then they suddenly become symptomatic because, again, I think they were like standing at the edge of the cliff and just something kicked them over the side. We looked at and compared our patients with POTS because the larger group of POTS patients we now have an autoimmune disease. We have now isolated the autoantibodies. Two other groups have published small studies. We now will have 100 patients, hopefully, that will publish. We will be ready for sending out the data. They have high levels of circulating autoantibodies to alpha-1 receptors in smooth muscle. But we looked through our patient data to try to compare these to the other patients. And this is just some of it, that the hypermobility POTS people, one of the things that distinguishes them is migraine. Other data has suggested that up to 70% of these people have migraines. 28%, about 19% is the general rate of migraines in the population, particularly among women. So that, but they also more frequently had syncope. They also had some other issues and all, but these were the two that stood out. The migraine and syncope were much more prevalent in the hypermobility people. There may be some, I'm fully convinced now that this is there's a lot that's not right. There's a diffuse lot of things that go on because you can find all kind of associations. Now, whether or not these will turn out to be valid or not, but I see that a lot of some of the kids I see, there seems to be, and I want to try to go back through it, a increased prevalence of things like autism spectrum disorder, Asperger's syndrome, et cetera, and also other neuropsychiatric problems that I think are somehow related. A lot of these people get extreme scars. This is after a lady had a laparoscopic surgery and the wound just fell apart. So that one of the things about the hypermobility people is they get sick earlier in life. As a matter of fact, if you have somebody come in the clinic that says, I've been sick since I was a kid, before you even look at them, the chances are that they're going to turn out to be an EDS or hypermobility people. So this is a group of disorders, and this is the chart that now we adopted that's now the international framework for diagnosing these. And so this is a group of different disorders. So again, it's not one thing. So before we start treating people, we try to recondition them, enhancing their skeletal muscle pump whenever possible. The water is really a great place for it because when you swim, you're horizontal, you're not vertical. There's no gravitational displacement. In addition, the water is a big compression suit. Physical therapy is done first, and we use pharmacotherapy to make them feel well enough that we can recondition them. And again, it's beyond the scope of this lecture, but there's a number of drugs that have been subjected to trials. We're now in the midst of doing multiple double-blind randomized trials. Having been sick, I had renal cancer. I'm one of the few people that actually survived it. Everybody in my treatment group died. And having lost my wife to brain cancer, and my daughter now has multiple sclerosis, I can tell you that one of the greatest difficulties you have in dealing with any illness is the emotional part of it. Indeed, looking back, the emotional part of dealing with cancer in myself was the major thing. I had the worst time with that. And again, it's not uniform because you bring your past with you to your illness. And so your past influences how you handle your illness. I was always astonished at my wife how much more courage she had in facing cancer than I did. I was a mess. So it's hard to condense, as I said, 30 years worth of research down into 25 minutes or so. But it's been a fruitful endeavor, and again, I think that the EDS people are their whole other separate world. But I'm beginning to think that the EDS people may have a higher rate of autoimmune disorders. And I'm really, in my heart of hearts, I'm convinced of that because as we've followed people longer, we're seeing people turn up with MS, with Sjogren's syndrome, and actually the autoantibodies that we have identified are very similar to the Sjogren's ones. They're not exactly the same, but they're similar. And indeed, there's a number of people that we're finding have a coexisting diagnosis of Sjogren's, and oftentimes the dry eyes, dry things and all. Interestingly, in ophthalmology, they feel that many of the people with the dry eyes and things like myself, because I went to my ophthalmologist and he said, we feel it's probably a mild autoimmune problem. You may not know this, but the rate of autoimmune disorders in Western society is increasing dramatically. In the last 30 years, there has been a 4-fold increase in the incidence of Crohn's disease. 4-fold. So the incidence of these are going up dramatically. So again, thank you. It's an honor and a privilege to be able to be here. And I think working together and at least asking the questions, we can try and figure out better how to help these people and how to care for them. So thank you.